Ladies and gentlemen, welcome back to another fabulous episode of the Healthcare Trailblazers podcast. Sitting today with the wonderful Dr. Eric Arzubi. Dr. Arzubi moved out to the middle of nowhere, Montana, and is building an absolutely incredible psychiatric practice. Excited to hear all about it. Dr. Arzubi, thanks for joining us today.
Well, thanks for having me.
Tell us about the kind of, you becoming a doctor and then moving out to Montana. What was that about?
Yeah, I'll try to give you the sort of the most efficient version of the story here, but really, I'm 55 now. When I finished college in 1991, and my first job, actually, I moved down to Argentina, worked with my uncle. He was in finance, and I quickly pivoted and actually got a job to be a reporter for Bloomberg. And was a correspondent for Bloomberg for a couple of years in Argentina, then moved to New York. And then by 1994, I got myself a job at Morgan Stanley working as a bond trader. And, so I'm in my 20s making good money in New York City, things are pretty good. But, after a couple of years of that, I started just, I get in my head a lot and I start questioning the heck out of what am I doing with my life? This is my one shot at life. And I just couldn't imagine me being 70 years old and still buying and selling, financial instruments. And the other thing is, role models and mentors are important to me. And looking around, I didn't see people who I wanted to be like when I was sort of their age, right? And the only person I kept thinking about was my pediatrician, who he was my doc from when I was 9 months old. And he, I grew up in Vermont. And, I kept calling the poor guy even when I was 22, asking for medical care. He's like, dude, you gotta go find an adult doctor. But I just liked the guy and I respected him. I looked up to him and I just kept thinking about him as a role model. And so 1999, after lots and lots and lots of thinking and talking and, it was real tough to make the decision. I left and I started doing pre-med work at in New York City at Columbia, and immediately and I always loved the sciences, immediately fell in love with the coursework. But, 9 months in, actually, I uncovered, either I uncovered or triggered a severe bout of anxiety, which was really pretty crippling and really required me to kind of take an extra year. And I think in many ways that informed probably my decision to become a psychiatrist. And because that was my first encounter with psychiatry, mental health for myself. And I think it also taught me that I'm not Superman and I have my limits. And so I think that was an important thing to go through. And eventually I started medical school at Yale in 2003. I stayed in New Haven all the way until 2013. I finished my psychiatry residency, child psychiatry fellowship. And in 2013, on what's probably close to a whim, moved to Montana. I got this email, Billings Clinic was looking for a psychiatrist. By that time, I was married, had two daughters who were about 7 years old. And, my wife and I, we wanted a different life for our girls. I didn't want them growing up in, really intense Northeast where it's super competitive. I'm like, I'd kind of burned out on that. And I'm like, I don't want my girls to necessarily go through that. So we moved to Montana and got a job at Billings Clinic and had a career there for 6 years. Loved it, learned a ton, surprised the heck out of me in terms of the healthcare deserts that are out here in states like Montana, Alaska, Wyoming, and definitely found my purpose. So that was a little longer maybe than you would have loved, but that's kind of the arc of what I've gone through.
No, I don't think you could have made that any shorter. That's quite the story, and quite the different story. How old were you when you went back to school?
So I started my pre-med work. It was January of 99. So I was 29 and I turned 30, a couple months after that. So
that's amazing.
And because of kind of the anxiety episode I went through, that added a year, and then one of dumber decisions, but very but I would say very, very fulfilling and educational. But I think maybe a dumb decision was trying to start a business while I was doing all my pre-med work. I don't think I've told you this story. I started to make extra money because I'd blown through whatever savings I had to pay for pre-med, and I loved teaching. And so I started tutoring kids in math and science, then test prep. But then a lot of families started asking me to help their kids, their other siblings with like learning disabilities. They have ADHD. They get these neuropsych tests. And they don't know what to do. I love that. I'm like, oh my God, this is really cool. And so I'm like, oh, I'll start a business, because I'm Superman, still forgotten that I just told myself I'm not Superman. I think I'm Superman. So I'll start a business. We created this tutoring company called Raging Knowledge that was open for about 8 years. And we had to shut it down when the financial crisis happened in 2008, 2009. We just blew up. But I'll tell you, I tutored kids for about 8, 9 years during my training.
Wow.
Thousands and thousands of hours of spending time with kids and family. And that's really what ultimately nailed down my decision to become a child psychiatrist. I loved spending time with the kids. I felt I was good at it. I feel like I finally found something that's me, that I'm passionate about. That's my thing. And that was awesome. So again, I'll take the lumps and the bumps, but on the other side, I learned a heck of a lot about myself.
Wild story. So let's really dig into Montana. So you get there, you unpack your bags, you look around, you see the beautiful mountains all around you. Let's talk about the state of healthcare. So what were kind of your first impressions, and maybe culture clashes? But yeah, what did the landscape look like from a healthcare perspective?
Super interesting, very different. So again, when I first interviewed Billings Clinic is the biggest healthcare system in Montana, and it's a local system. Now Intermountain Healthcare has come in to Montana. They bought a system that was in Colorado and in Montana. But in terms of the biggest local system of care was Billings Clinic, mm-hmm. and had lots and lots of sort of satellite critical access hospitals around the state and in Wyoming. So very big. And at the time, it was being run by a gentleman named Dr. Nicholas Walter. He was an incredible visionary, kind of one of those mentors that I enjoyed sort of thinking about and finding. Great guy. He had built Billings Clinic. Actually, in 2013, Billings Clinic was named the safest hospital in the country by Consumer Reports because of the work this guy had done. So I was really excited about joining. Anyway, one of the things I learned very quickly is the state of affairs when it comes to these long distances, and really understanding that the social determinants of health in a rural state are very different than the social determinants of health in a more urban area. And right, because we talk in general about social determinants of health, but they're different depending on where you live.
Yeah.
So for example, if somebody, let's say I have major depressive disorder in Billings, Montana, and let's say another, a copy of me has that in New York City, the symptoms are the same, but the outcomes are different, right? So there's still major depressive disorder, but outcomes are different. Why? Because it depends where in Montana I live. There are very few psychiatrists. And if you do find a psychiatrist, you got to drive a heck of a long way if you don't have telehealth to get care. So when I arrived, I had families that were driving 4 or 5 hours to meet with me for a half hour.
Oh my
okay.
goodness.
So they were coming from tiny, small town Montana, let's say northern Montana. These guys would drive 4 hours. So what would happen is mom would miss work, the child would miss school, and they'd have to spend all this gas money just to come down and sit for a half hour with me. I'm not that exciting. Like half an hour with me, I don't, but it's brutal that had to happen. Now, Montana has one of the earliest, one of the earliest telemedicine networks in the country. There's something called the Eastern Montana Telemedicine Network that was started in the early 90s, I think like 91, 92. So when I arrived in Montana, there was already a pretty active telemedicine network, but it was built on the super expensive Polycom piece of equipment. You had to spend 20 grand just to set up a cart. And so people still had to, even if you were in the vicinity of one of these, you still had to drive 2 hours to that clinic to then connect over telemedicine with me. So it still wasn't set up where people could do this by the phone or computer from home, right? But telemedicine was there. Montana already had regulatory environment that was conducive to doing telemedicine. Parity existed for the delivery of telemedicine. So all that was great. So again, Montana in many ways pioneered, I think, the setup of telemedicine networks, and actually one of the first presidents of the American Telemedicine Association is actually the same person that ran telemedicine at Billings Clinic and is a friend of mine. But so it's really interesting the role that Montana sort of played in pioneering telemedicine. So that was one of the things that actually excited me about coming here. Interesting that one of the things I kind of learned, and to me is a great telltale of the distances that people travel. If you look at the distance between let's say the southeast corner of Montana and the northwest corner, that distance is exactly the same distance as the one from Chicago to Washington, D.C. That's exactly the same distance, but in that area, you only have 1 million people. And in the other area, you got millions, right? So the population density is just really low. You have big healthcare deserts and really difficulty access, just all sorts of barriers, right?
Yeah. Yeah.
Yeah.
The obvious answer to that is telehealth, which is probably why, they pioneered it, because it's kind of the obvious answer, especially something like psychiatry, where it can be done a lot more effectively over telehealth, rather than, I don't know, primary care. The doctor still needs to feel the patient,
Yeah, exactly.
So let's fast forward a little bit to today, because how has that kind of been adopted? How important is telehealth? What are some of the challenges? My understanding is that a lot of rural America still doesn't have very good broadband and just internet to be able to connect to some of these services. So let's fast forward to today. What does the landscape look like over there for telehealth currently?
Sure. So right now, you're right. There are parts of Montana, as well as other rural states, that have pockets where broadband is not easily available, or it's really spotty, right? And just as one aside, sorry, and this is probably statistics I should have called out up front, is the most rural states are also the ones that have kind of the worst mental health statistics. So Montana, Wyoming, Alaska, for the last 40 years have been among the bottom 3 in terms of worst suicide rates in the country. And add to that, there were no psychiatry residencies in any one of those 3 states. Montana only got its first medical school, 2 years ago. So just lots of layers to this. But back to your question, obviously COVID accelerated the uptake of telemedicine for both psychiatrists as well as patients, because before COVID, because we started thinking about this and actually created the business entity before COVID started, because we really believed in this. But there were a lot of psychiatrists that were still skeptical, going, well, in person is better, and I'm like, yeah, okay, in person might be better, but let's compare it to what's really out there. You get the options are, for my patients that I take care of, telemedicine, nothing. That's what we should be comparing to. We can't be comparing telemedicine to some ideal.
Yeah.
That's just not fair, right?
Yeah.
So sorry, it's a really roundabout question, because you're asking good questions that are kind of making me think about a lot of other issues here. But the broadband situation has not been a huge barrier to us.
Okay.
Because what happens is now, what's great is people have smartphones, right? So if somebody, let's say, has spotty internet in their home, they can drive. There's always going to be kind of some local town, some local outpost that's going to have, a cell tower or Wi-Fi. So, for example, they can pull up next to one of their stores, and the store might have Wi-Fi. Local library. There might be a local critical access hospital that allow them to go into the lobby and sit there and use the Wi-Fi, right? Yeah. So again, the way I'm thinking about it is,
sorry to interject, but I think that with Starlink, I think Elon is really solving for a lot of this as well. No?
Yeah, 100%. Actually, a couple of our providers have Starlink.
Yeah.
I have one nurse practitioner of ours, is a wonderful nurse practitioner out of Montana. She will, in the summer, will actually take 2 months and go around in her RV with her husband and use Starlink to take care of patients from her RV. So yes, Starlink works.
Yeah. Sorry, no, I cut you off, but
No, that's totally fine.
It hasn't been a very big barrier. Okay, so
not really.
So it's not, so that's not an issue. Adoption is very high, especially post pandemic. But and I agree with that. Like, with our services at Proviva, I mean, we saw this huge. It was a paradigm shift for patients and doctors. Whereas before, well, you're going to call me once a month. You're not at the office. I don't remember seeing you at the office. To, oh yeah, this makes sense. Now it's like not even a question, and it's
Right.
it's actually wild how far we've shifted that perspective in literally just 2 years. I mean, it's pretty crazy.
Absolutely. There are a couple of things. Look, it's definitely not all smooth sailing, right? If you're trying to build an all virtual practice that delivers psychiatric care and addiction treatment, which is what we do, right? So we take care of all ages. We have child psychiatrists, we have geriatric psychiatrists, I have addiction psychiatrists, we have general psychiatrists, and we have about 30 providers, about half of whom are MDs, and then the other half are nurse practitioners, physician assistants. So we got a great team. They're kind of all over the country. But as we grow, right, because our goal is to be great at the medical side of mental health and addiction, right? So we're not looking to be all things to all people. We want to be fantastic at delivering psychiatric care or addiction treatment in rural communities. And so, start in Montana, we just expanded into Idaho. By the end of the year, we'll be in Alaska, and we're trying to do this in a deliberate, thoughtful way. Yes, we took in some a minority investment from a growth equity partner, but we were very picky to work with an investor that was aligned with our long-term vision. We did not want to be a company that grew so fast that we break things. Not gonna do it, because we want to have an impact in every community that we touch. We don't want to just be at the 40,000 foot level and say, hey, we're in 30 states or 40 states just to make investors happy. We actually want to have an impact in each one of these. So that being said, still expanding state to state has its own challenges, right? You didn't need a medical license in each state that you practice. Then each state, you need a separate DEA license to be able to prescribe controlled substances for ADHD, for anxiety, right? Or MAT, which is medication assisted treatment for opioid use disorders. So, we knew Montana well. This is where we started, but I'll tell you, every state has its own quirks. We had a heck of a time trying to wrestle with the DEA to figure out the right way to set up our DEA licensing in Idaho. That was a whole episode. And then Alaska's really struggling. It's amazing, right? Because Alaska is one of the states with the biggest needs for mental health care, but the friction that you have to experience in getting licenses, permissions, DEA license. And Medicaid Alaska is taking forever to get us enrolled. So it's not like you just flip a switch and you're like, oh, boom, we're in Idaho, boom, we're in Alaska. It's a challenge, and it's unfortunate. I think it's one of the unfortunate things of healthcare that my partner and I. So my partner's name is Dr. Reza Hosseini Gomi. He's based in Seattle, and we reflect on this a lot. Like, the needs are huge, but the barriers are huge. Even barriers are huge for patients, and they're huge for providers. And it's unbelievable how difficult our system, our structure has made it to try to deliver care. I mean, our hope was we wanted to make it easy to get care and easy to deliver care. But man, the system does not help.
Yeah. The biggest challenge is one, I think, in my mind, is 100% around the regulation, red tape. But I'm really fascinated by something that you mentioned at the beginning of the conversation. I'd love to kind of double click on that. Can you give some more insight into some of those differences around social terms of health? Because based on geographical location, I find that really interesting because, like you said, social terms of health has kind of just been this blanket statement. Here's a list of questions. Ask all patients all these questions. And I was in Miami. We did this really great panel podcast with a bunch of really great folks. It actually wasn't Healthcare Trailblazers. It was Brian Urban's podcast, Healthcare Rethink. And I was reflecting on how social terms of health it's a means to an end. It's a means towards health equity in the sense of presenting healthcare to people in the way that makes the most sense to them,
Yes.
and obviously that is cultural understanding, but also geographical understanding. And with our work at CareCo, it's something that I'm specifically interested in because, in building out this brain for care coordinators, that's my vision, is to really incorporate a lot of that kind of psychology and persuasion to the minute detail of like, what zip code do you live in versus what zip code do you live in? And then, based on that and your race and your gender and your age and everything, what's the best way to kind of approach you in this conversation? So to hear you kind of talk about this from real rural America is very interesting to me. So sorry, long-winded question, but if you could maybe give some more examples and really double click on some of those SDOH differences in rural America versus, where we are.
Yeah, no, absolutely. Right. And just as a reminder to listeners, right, mortality and long-term health outcomes are only 10 to 20% dependent on, the quality of healthcare. And so the remaining, right, are these are genetics, and the rest is social determinants of health. And in rural America, there's some kind of key differences. No, first of all, they're certainly cultural, right? Because the type of work and the economic drivers in rural America are very different than they are, let's say, in a state like New York, or especially in urban areas, in San Francisco. Big cities everywhere, right? So the economic drivers in a place like Montana, for example, there's tourism, there's farming, ranching, there's some fracking in sort of remote parts of Montana in the Northeast and close to the Dakotas, and so the type of work that's available is very different. Number one. Number two, the state's most vulnerable populations are different than what you might find in other states. So Montana, for example, has 11 Native American tribes and 7 Indian reservations. And the socioeconomics and the cultural differences are very pronounced among those populations. Montana also is top 5 when it comes to the number of military veterans in the state. And so you can imagine that's also a specialized need. Military veterans in Montana, like most places, have a heck of a time getting the care they need from the VA, so they have to rely on outside agencies. As an aside, an interesting tidbit for me that I was learning as we're learning about the states we're entering. Alaska actually has over 200 native tribes, which is just fascinating to me, right? And in the United States overall, there are over about 400, somewhere between 400 and 500. Wow. Alaska has about half of them. So anyway, so just kind of little examples. Then what else? In terms of economic stability, like rural areas tend to have higher rates of poverty and unemployment, and we know those factors are linked to poor health outcomes over the long term, and also difficulty accessing healthy food options.
I was just going to say, it's like the not only is the diagnosis, so to speak, on the SDOH different, but also the prognosis or the prescription or however you want to call it is also like in some urban area. The issue is that there's a lot going on, but there's no healthy grocery stores, versus in the middle, there's nothing. There is no grocery store. There's nothing.
Right. And you'd think, right, because being a farming and rural community, you should be able to see like healthy food options, fruits, vegetables everywhere. And it's the market's it's still expensive relative to a cheeseburger at McDonald's, right? And so not that there's McDonald's everywhere, but you know what I mean. Like the still healthy food options aren't any cheaper in Montana than they are in the rest of the country. Then the other kind of factor to keep in mind is educational achievement in rural areas tend to be on balance lower than in more urban or metropolitan areas, and so less likely to complete high school or get a college degree. And so that affects health literacy, long-term behaviors and outcomes. A statistic that recently came out is Montana and some of the rural states have the highest rates of binge drinking in the country. So again, think about culturally. If you're in a rural place, you have fewer economic possibilities, fewer educational opportunities. And but liquor stores are plenty, and you can find those in any town, right? I mean, those are things that certainly play a role in terms of people's healthcare outcomes and the choices
Yeah.
that are made. And then certainly access to healthcare, right? So yes, telehealth helps, but the problem is still, if you're someone experiencing a crisis, a mental health crisis in very rural Montana, you can go to your local critical access hospital, but what's going to happen there is the emergency room doc is going to hear, okay, this patient is suicidal. Now what's going to happen? That patient, if the patient wants to go home, the patient may be held against his or her will at that point, and then has to be transported for 4 hours to a hospital that has a psychiatric care available. Now, when I was at the Billings Clinic, right, I started Frontier Psychiatry with my partner late 2019. We started seeing patients 2020. But when I was part of the healthcare system, it was super common, Mendel, super common, where a patient would be sent, sometimes even by small plane, okay, to Billings Clinic for a psychiatric assessment. The patient actually didn't necessarily meet criteria for hospitalization, but the doc that saw him or her, 500 miles away said, "Oh, I don't know what to do with this. I need to send them to Billings Clinic." I do an assessment, and I find they don't necessarily meet criteria.
Yeah, they're
Well,
stuck.
now they're stuck 5 hours. Now they're stuck 500 miles away from where they live, and that was not uncommon, right? I mean, so think about what that means for that patient, and what are the chances that that patient is ever going to ask for help again?
Yeah.
Right? I mean, if that's the side effect, if that's a side effect of asking for help, is that you get dumped 500 miles away from where you live,
That's wild.
and you're stuck there.
Yeah, no, I mean,
That's not great.
I think it's really hard for people
Right, so
that live in more urban areas to really comprehend. I mean, I grew up in a tiny town in Iowa, actually, for about 4 years of my childhood, and I just remembering this now. My older brother was once riding his bike, and I guess he crashed or he got hit. I don't know exactly, but someone found him on the side of the road, just unconscious, and anyway, they woke him up. We put him in a car, and my mother proceeded to drive 2 hours to the nearest emergency room, where the entire way he was asking her repeatedly what was for dinner, and then she would answer him, and then 2 minutes later he'd ask again, and she's freaking out, and she's just driving 2 hours to
yeah.
Oh my goodness, it really is crazy. It really is crazy. But what you're describing is at a whole nother level. I mean, you get flown out, 500 miles, and then now you're just there. You've got the clothes you came with, and that's it.
Yeah, absolutely. Right. And so the thing about the burden also this puts on the healthcare system, because, I, as a doctor who I like to think cares about the patients, I'm not like, so then I have a choice. Hey, buddy, you don't meet criteria, so peace out. Good night. It's 11 o'clock, and he has to find a way to get home. 500. That's 500 miles away. I'm not going to do that to that person. So the healthcare system, right? So Billings Clinic has to take on the burden, not burden, but to support this person for the next day or two, because the healthcare system pushed him down there. Abandoning the guy isn't a very empathic thing to do. So maybe we keep him overnight, which is at an expense to the healthcare system, right? So the healthcare system often, absorbs these huge costs that are really attributable to poor infrastructure that doesn't allow for, or maybe a kind of very risk averse decision 500 miles away. They're like, oh, suicidal. I don't know what to do. Send them away. That's not
so.
That's
I mean,
not
the
great.
introduction
That's
of
not great.
telehealth and the continued adoption of telehealth, and especially, like we talked about, it's getting better and better. You've got Starlink now. You've got local options that you can go with Wi-Fi. You can take your phone. You don't need this $20,000 cart that years ago. And so we're definitely getting there. But let's talk about reimbursement, because that seems to have trended downwards after the pandemic, which I find to be strange. So, but I'm not as plugged in as you are. What's the current state of affairs from a reimbursement perspective around telehealth, and where's it trending?
Sure. One of the strange benefits, no, not so strange, actually makes a ton of sense, right? That Montana in general is telehealth friendly. And so the the U.S. senators in Montana, so Senator Daines and Senator Tester, one's Democrat, one's Republican, both support this, right? Mental health is one of the very few kind of issues that both sides of the aisle will sort of champion. They might champion it for different reasons, but they'll champion them, right? And so I don't care, just champion it, and I'll run with it. And so we get support from the U.S. senators. We have only one representative that's a supporter, and then the Governor Gianforte, also a big supporter of using technology to make healthcare more available. So I would tell you that the political will and support is there. So locally, we're not facing huge headwinds locally when it comes to that sort of thing. And again, the governor before Gianforte, Governor Bullock, who was a Democrat, Gianforte is a Republican. Again, both of them very supportive. So that makes things a little bit easier. And so it's easy to get an advocate. So if something weird starts happening regulatory in terms of regulations, I feel pretty lucky because we are a small state. We have good access to our senators and the governor's office to really help us advocate and really try to smooth over some of the barriers. That's been helpful. And actually, some of these policymakers have actually made some really kind introductions for us into Idaho and Alaska, so we can have also people to call when we're running into some barriers. So I guess, as an aside or maybe an important point to make is I think as physicians, if we're trying to do something different, out of the box, innovative, like really, really understanding all the different levers to pull to really to advocate for our patients and to advocate for better care, get to know your local representatives, your local senators, and the governor's office, right? Because we need to be able to advocate for our patients and advocate for better care when some random regulations start getting in the way, right? So that's been good. One of the things that's got us a little bit nervous is we're still waiting to hear from CMS what they're going to do in terms of telehealth, telehealth regulations, as well as the DEA. So both of them, by the end of December of this year, need to be coming out with new rules because they've kind of punted and procrastinated to kind of come up with final rulings. So I'm hoping that'll remain telehealth friendly. But again, that was a very long way to answer your question, which was in the rural areas, there's going to be a strong reaction, at least from local policymakers and stakeholders, if telehealth in some way is either they start putting administrative barriers on top of it, or if they start pulling back on funding. Because at least what I can say for you, Montana, they've not cut back on reimbursements for telehealth.
Well, yeah, go ahead.
And yeah. No, I was just going to say, right? So the policymakers, the leaders, the politicians, they're super aware that the delivery of healthcare in our states looks very different, and so they know that, and they hear about it all the time. But there's still, and I think when you and I maybe first talked offline, there's still some other layers of discrepancies and sort of discrimination in rural areas. So like I mentioned to you, like no medical schools, they're like, how the heck are we going to train doctors? Then, there's no psychiatry residency in any of the 3 states. It took me a couple of years, but I got us to get a psychiatry residency in Montana because I felt it was important to 2 things. Number 1, train psychiatrists here, but number 2, train psychiatrists differently. Train psychiatrists understand to understand that the social determinants of health you're facing here are different than you would get trained in somewhere else. So when I did my training in New Haven at Yale, I had no clue about the social determinants of health in a place like Montana, and in some ways, shame on me. We need to be, I don't know, my next sort of thing that I'm going to be championing or thinking a lot about is training psychiatrists differently. Just because, being trained, every year we train 2,000 psychiatrists. They get spit out of the system and they go practice. But for God's sake, we don't even have a mental health crisis anymore. We have a crappy new normal, right? It's not because a crisis is like a time limited thing, right? That's a crisis time limited. Like you fix it and the crisis is over. really a 20-year crisis is kind of a chronic condition now, right? And so we need to be training psychiatrists very differently, because I feel like we need to own this problem, right? We can't be punting it to other people. Like, we need to own this. We need to be taught and trained how to have the skills to be creative and think outside the box to solve this problem. Because if we keep training psychiatrists the same way we've trained them for the last 50 years, 20 years from now, Mendel, you and I are going to talk again, and we're going to have the same damn conversation about what a problem all this is. And that, to me, is not okay.
No,
so
I think
sorry, that's my little
listen, it's fascinating to hear your perspective on the ground in not just Montana, but these other, Alaska and these other states that are just really, really rural. It's so important for these, for thoughts and voices like yours to be heard. And so, I thanks for spending time today. And you're doing God's work out there. And I wish you tremendous continued success. Look forward to continuing to see the progress.
No, I appreciate it. And thanks for giving me even just a few minutes to kind of voice really and try to be a champion for the needs of folks in rural communities, and really to really hopefully be a loud voice to just bring attention to the issues here, because there are big healthcare disparities in this part of the country. Absolutely. And we need to address them. So thank you, Mendel.